I think we'll go ahead and begin. Welcome. My name is Helen Healy. I'm a neonatologist at the Beth Israel Deaconess Medical Center in Boston. It is my pleasure to start the Tiny Baby Collaborative webinar today on hydrocortisone for infants born at or less than 23 weeks. Our speakers today, who are also authors of a recent review article on this topic, are Satoshi Kusuda from the Neonatal Research Network of Japan and Dr. Erik Jensen from Stanford University. Our moderators will be the esteemed Dr. Kristi Watterberg, our colleague Dr. Dustin Flannery, and Veronica Smedbäck, who is a NICU nurse by training, now also a physician and PhD student who has recently authored an observational study on use of hydrocortisone in this population in Sweden. A couple of our usual housekeeping items. This webinar is recorded, and the recording will be posted to the Tiny Baby Collaborative website. We do encourage multidisciplinary attendance, including that from families. And we ask that you please use the question and answer section section of this. We will have discussion of those questions at the end. If you use the chat feature, we will be able to see those messages, but we will not be able to respond to the group. Our next webinar will be at the same time, 4:30 Eastern Time on May 18th, and that will be on establishing a Tiny Baby Tiny Baby program. Next month, PAS will be taking place. There's a number of events we'd like to make sure everyone knows about. The Tiny Baby Collaborative meeting will take place on Friday, April 24th from 12:30 to 2. And this will be a 90-minute panel called Ask the Experts with patients and families. There's also a neonatal less than 25 weeks poster session and neonatal less than 25 weeks oral abstract session. The poster session will be on Saturday afternoon, and the oral abstracts will be on Sunday afternoon. So we invite everyone to please join us if you're in attendance. Now, looking at those who have registered for this webinar today, as in the past, we're joined from people from over 50 countries. About 65% are registered from the United States. About 2/3 are neonatologists, and the other third is multidisciplinary providers. We asked registrants, particularly clinicians, to report on their use of hydrocortisone in various scenarios. For prophylactic hydrocortisone, meaning started less than 24 hours of life, in infants less than 24 weeks, about 1 in 6 reported that they do this practice, and another 1 in 6, about 14%, said this varies by provider, but the majority said they do not start prophylactic hydrocortisone less than 24 hours. Regarding the decision to use hydrocortisone to treat hypotension less than 24 hours, about 1 in 5, 20%, reported using this as the first-line agent and half as a second-line agent. Only 9% reported not using hydrocortisone for hypotension. And then regarding the use of hydrocortisone for lung disease started after 1 week of life, about 1/3 reported that they do this practice and 2/3 do not. We also asked how hydrocortisone is dosed in your NICU. The majority, about 82%, use milligrams per kilo for dosing, but some 18% dose based on body surface area. And finally, a minority, 19%, measure a cortisol level prior to starting hydrocortisone. The majority, however, do not. So this is what the registrants, those of you joining us today, have reported. We also want to look at what our Tiny Baby Collaborative centers are doing. So looking at over 2,000 patients now entered into the mini registry, we can see that most babies born less than 24 weeks in this registry do receive hydrocortisone for some indication, and more than 1/3 of those have that hydrocortisone started on their first postnatal day. Most of the babies that are treated have hydrocortisone started in the first week of life. The median day to start hydrocortisone for babies born at 22 weeks is day 2, and it's 6 days for babies born at 23 weeks. Looking at this last data slide showing center-level variation in hydrocortisone use, where each dot represents the percent of babies to receive hydrocortisone for either indication at centers that reported greater than or equal to 10 infants at each gestational age. You can see that there's very wide variation in hydrocortisone use across all hospitals. However, all hospitals reported that they used hydrocortisone in at least some of the babies that were entered into this registry during this time period. So we can see that our use of hydrocortisone is extremely varied and used for various indications. So we are excited to welcome our speakers today. to give us their guidance on how we can best, most appropriately use this medication for our patients. With that, I will turn it over to Satoshi.
Hello, everyone. Let me share my slide first.
I think if you just choose to share again at the bottom. Looks great.
Okay. So again, I'm Satoshi Kusuda, neonatologist, working in Tokyo, Japan. I'm so happy, and also I'm very honored to share our experience about how to use hydrocortisone for tiny infant today. I have nothing to disclose this presentation. Today, I'm going to talk about what's the physiology of adrenal function in preterm infants. And then I want to share why preterm infant may show the adrenal insufficiency during NICU stay. And then I want to present the incidence of adrenal insufficiency among extremely preterm infant. And finally, I want to touch on how to use the glucocorticoid in case of hypotension, actually rescue use of hydrocortisone for hemodynamic support. However, probably due to the insufficient data, especially infant born before 24 weeks of gestation, some information were obtained from infant born at later gestational ages. So first, this is how look like the adrenal gland and kidney from term infant. You can see relatively big adrenal gland on the top of kidney. The adrenal gland is almost adult size. However, kidney is only 1/10 of adult size. That means adrenal gland of newborn infant is relatively large compared to their body size. This slide shows the absolute and relative adrenal gland weight before birth and also after birth. You can see the weight of adrenal gland just before birth is actually largest, highest. And then after birth, it reduced its size dramatically and then grow gradually and may take more than decades to reach to the adult size. Open circle shows the relative weight compared to body weight of the adrenal gland. And red yellow shows the almost time of tiny baby infant. That means born around 24 weeks of gestation. So you can see, again, the weight of adrenal gland is very high during fetal life, and also around 24 weeks of gestation is the almost highest adrenal gland weight during fetal life. So adrenal gland is so large in fetal life. We usually think it's functioning very well and also matured already during fetal life. But it's not true, actually. Most of adrenal gland before birth consist of fetal zone. Fetal zone consists of almost 80% of adrenal cortex. And other 10 or 20% consist of actually adult fetal, adult zone. That means they have a function of similar to the adult adrenal gland. So even adrenal gland fetus has a big size, but still they do not have enough capacity because of most of them consist of fetal zone. So what fetal zone is doing? So this is a steroidogenic pathway of the adrenal gland. Most of actually steroid hormones produced by cholesterol, and then it converted to several metabolites by several enzymes. And usually on your left, fetal zone corresponds to the zona reticularis in adult, and they produce mainly steroid hormones, sex hormones, androgen and estrogens. And middle of this figure, you can see the function of definitive zone. It corresponds to zona fasciculata in adult. They can produce cortisol. So again, most of the fetal adrenal consists of fetal zone. That means 80% of fetal adrenal function is related to the producing sex steroid, mainly estrogens. This is actually enzyme expression during fetal life, according to the zone and also according to the timing. You can see at mid-gestation, actually, you please remember the key enzyme to produce cortisol, so-called 3-beta hydroxysteroid dehydrogenase. It's represented as HSD3B2. You can see no enzyme activity in fetal adrenal gland of this key enzyme. However, other enzymes to produce estrogen already exist at mid-gestation. And late gestation, you can see the activity of HSD3B2, and also still enough enzyme to produce estrogen. So what this means, fetal adrenal can produce enough estrogen, but cannot produce enough cortisol because limited capacity of 3-beta hydroxysteroid dehydrogenase activity. To show that function, there are experiments using cell culture from mid-gestational fetus. And this slide shows the production of DHEAS. It's actually a metabolite for the used for the producing estrogen. So this is actually source for sex steroid. And also open square represent cortisol. And these cells are stimulated by HTH. And clearly you can see these cells can produce DHEAS according under the HTH stimulation. However, cortisol production is not enough. That means, again, fetal cortisol can produce enough sex steroids. However, cannot produce enough cortisol. So because of this actually basic experiment, we can say the roles of fetal adrenal cortex is producing many metabolites, source of estrogen, actually to mothers. And less importantly, they producing cortisol. It's of course critical hormone for human being, but that amount is not large, very small amount. So adrenal cortex of preterm infants has a limited function in terms of producing cortisol, but well-established function to produce estrogen because it's essential for continuing pregnancy and also ends of the pregnancy to deliver newborn infant. So if I summarize that the characteristic of fetal adrenal function, this is a steroid synthesis pathway with placenta and mother. Again, you can see fetal adrenal gland produce pregnenolone from cholesterol. However, the next enzyme, 3-beta hydroxysteroid dehydrogenase, is not exist enough in fetal adrenal. They cannot produce progesterone. So most of the metabolite goes to the sex steroid and then provide to placenta, then provide to mother again to continue the pregnancy. In order to produce cortisol, fetus get the progesterone from placenta. So this means fetal adrenal gland, placenta, and mother, it's a kind of unit to maintain the pregnancy, also maintain the fetal life. So this is a kind of unit. It's very good before delivery. However, once fetus delivered, the supply of progesterone from placenta is suddenly interrupted. So what happened once fetus delivered? Of course, progesterone decreased dramatically. This is actually RCT using E2 and progesterone replacement to the preterm infant. So open samples represent the serum progesterone concentration of the control infant. So control infant didn't receive supplementation. And you can see rapid decrease of serum progesterone concentration on day one, probably, please remember, this is a logarithm plotting. So on day one, almost only 10% of progesterone remained on day one, and then again rapidly decreased. That means the dose of cortisol production is so limited once the infant born, and especially born at preterm. And when key enzyme called 3-beta hydroxysteroid dehydrogenase matured, this is actually analysis of the urinary concentration of several steroid metabolites. And this study shows at 30 to 33, between 30 and 33 corrected age, it looks matured. But before that, it's very difficult to have produce the cortisol with a limited capacity of 3-beta hydroxysteroid dehydrogenase. I am only talking about the capacity of producing cortisol in adrenal gland. Of course, preterm infant also has a less response under the stress. This is actually study of the pituitary and adrenal gland axis. And preterm infant showed less response to the TRH because peak level of ACTH at 2 weeks is less than 10 preterm infant at term. That means pituitary adrenal axis is also immature in preterm infant. So that's why preterm infant has a two limited capacity. One is producing cortisol in adrenal gland, also limited response to the stress. That's why preterm infants tend to be fall in adrenal insufficiency after birth. You should consider this situation of adrenal function of preterm infant. So how to actually diagnose the adrenal insufficiency in extremely preterm infant? Actually, again, we already said adrenal function is so limited, and probably under the mild stress, it doesn't matter. However, if stress exceeded, maybe very difficult to cope with those kind of high stress. So once easy to develop adrenal insufficiency, and once hemodynamic condition deteriorated by adrenal insufficiency, we need actually glucocorticoid to restore that situation. Glucocorticoid is the only way to restore that situation. Actually, however, we don't know, we do not have actually good marker or good way to diagnose the adrenal insufficiency in preterm infant. So in clinical situation, we have to do the diagnosis by step-by-step approach. So there are several timing to use hydrocortisone. This slide shows that timing of hydrocortisone at acute phase and also post-acute phase of preterm infant. Of course, if baby show hypertension, we need to rule out other cause. And then we need to hydrocortisone. Once hydrocortisone improved the condition dramatically, we can diagnose the baby had adrenal insufficiency. So this is a kind of clinical diagnosis. And also, even 1 week after birth, still we may have a chance to see the late onset adrenal insufficiency. This time, again, if hydrocortisone recovered that hypertension, we can diagnose the baby had adrenal insufficiency from clinical diagnosis. Actually, there are two types of insufficiency, adrenal insufficiency. One is primary, it's a decreased serum cortisol levels, and relative, maybe normal or even higher cortisol level. But theoretically, there are two types. However, in clinical practice, it's very difficult to differentiate this type of adrenal insufficiency, especially measuring cortisol level in serum during in preterm infant. It's very, very problematic because there are many metabolites actually react to the immunoassay antibodies. So it's very difficult to see the real concentration of cortisol in preterm infant. We need mass spectrometry to actually measure the true level of cortisol in preterm infant. So from clinical point, almost impossible. So we cannot differentiate this type of adrenal insufficiency in preterm infant. Okay, so from here I want to share what's the incidence of adrenal insufficiency among preterm infant. This is actually trend in the use of hydrocortisone for hypertension among extremely low birth weight infant in United States. You can see increased trend in use of hydrocortisone for hypertension, and almost almost more than 40% of infants received hydrocortisone for treating the hypertension in NICU among extremely preterm infant. This is a survey done in Japan. We asked how often do you use hydrocortisone within 3 days after birth for infant born at 22 and 23 weeks of gestation. And more than half of institutes said use, and also they said more than half of the infant received the hydrocortisone. So probably many infants born at 22 and 23 weeks of gestation needs hydrocortisone to stabilize the hemodynamic condition after birth. Also, not only acute phase, also in late phase, they have a limited capacity to produce cortisol. That's why they may show the late onset adrenal insufficiency, especially among very low birth weight infant. This is a kind of concept of late onset adrenal insufficiency. We call late onset sacral collapse. So even 1 week or longer after birth, they may show a sudden decrease of blood pressure, decreased urine volume, and increased body weight. And we can, if we can rule out hypovolemia and sepsis, we can say this is a late onset adrenal insufficiency among preterm infant. So this is the incidence of late onset adrenal insufficiency in the United States. Infant born at 23 weeks, maybe 50% showed late onset adrenal insufficiency, 24, 30%, 25, 15%. So clearly, if baby born more prematurely, they may have more chance to show the adrenal insufficiency, even late phase. This is the incidence of, again, late onset adrenal insufficiency in Japan. Again, the incidence reversely correlated with the gestational week. At 22 weeks, 30%, 23, 25% of infants showed adrenal insufficiency later, maybe more than 1 week after birth. However, if we compare the incidence of glucocorticoid use for CLD or late onset adrenal insufficiency, you can see most of time we use glucocorticoid for usually preventing or reducing, preventing CLD or improving oxygenation during NICU stay. Much higher rate of the glucocorticoid used for treating or preventing chronic lung disease. However, you can see again, almost 1/4 or 1/3 of preterm infant born before 24 weeks of gestation, they may need late onset, they may need hydrocortisone to treat late onset adrenal insufficiency. Finally, I want to touch on how to treat the adrenal insufficiency among preterm infant. We call birth pressure resistant hypotension. We need glucocorticoid. That's why, in another word, glucocorticoid responsive hypotension. I'm not going to talk about treatment for BPD or any use of prophylactic purpose. What does glucocorticoid responsive hypotension means? It's related, of course, adrenal insufficiency, and adrenal insufficiency usually decreases the inotropic receptors, and this is usually relative adrenal insufficiency because under the stable condition, they may not show this situation. However, stress is so hard, especially just after birth. Maybe infants need more cortisol, but they do not produce. That's why relative adrenal insufficiency may occur frequently. And this time, we need only replacement of hydrocortisone. We don't need pharmacological dose of hydrocortisone. We just need physiological dose of hydrocortisone. It recovers the adrenal insufficiency rapidly. Actually, we don't know the effectiveness of hydrocortisone treatment for the refractory hypotension. It's very hard to do the randomized control trial. This Cochrane review shows the use of dexamethasone or hydrocortisone actually improves the blood pressure in a preterm infant. It's a significantly proved. However, if we look at the mortality rate, there are quite a few data available. So it's not significantly, we can say significantly reduce the mortality. So we can say glucocorticoid improve the blood pressure, but we cannot say it improves the mortality. What's the dose for the, actually, if baby may show glucocorticoid responsive hypotension? Dr. Watterberg recommended the physiological dose of hydrocortisone because this is just a replacement therapy. So it's reasonable to start with physiological dose of hydrocortisone. Actually, this is a survey performed in Canada. Most of centers use physiological dose of hydrocortisone to treat the hypertension in a preterm infant. So physiological dose is reasonable, and if they don't respond, of course, we can increase the dose. So in summary, fetal adrenal glands play a very important role to produce sex steroid, not only for the producing cortisol to the fetus. And this is the reason why many preterm infants need hydrocortisone during stay in NICU. They tend to be adrenal insufficiency. And also, once adrenal insufficiency occurred, we need adrenal glucocorticoid. Otherwise, we cannot treat that situation. And also, we can start the hydrocortisone at physiological dose. And if necessary, we can escalate the dose according to the clinical responses. Thank you for your attention.
We go straight into me. So I'm going to.
Yes, please. Thank you, Eric.
Cool. All right. Share. Start. That look good?
Great. It's good. Thank you.
All right. I have the great pleasure of doing the second half of this presentation on hydrocortisone. This, as was alluded to earlier, I think is a presentation for the Tiny Baby Collaborative based on a narrative and summary review that Satoshi and I, as well as Matt Rasavi, put together. The bits that I wrote and will be summarizing today are the use of hydrocortisone to reduce respiratory morbidity, the effects of hydrocortisone on in-hospital adverse outcomes, as well as on longer-term neurodevelopment. In terms of disclosures, I have a lot of the same things as Satoshi did, so I don't have anything financial to resolve. It's true, similar to what he said, and honestly, it's worse for my half of the presentation, that there really are no trial data on hydrocortisone that are specific to the babies that we're talking about in this collaborative. There are some subgroup of data that are available on smaller or less mature babies, and I'll present those when they're available. But if your hope is to figure out what to do with hydrocortisone in a 22-weeker, your guess is as good as mine. I will note that oftentimes we're asked to talk about the off-label or unapproved use of medications. And since 2016, if you're living in the United States, preservative-free hydrocortisone has been approved by the FDA for administration of preterm infants with primary and secondary adrenal insufficiency, or those who have serious trauma or illness, or are known to be adrenally insufficient, or when adrenal cortical reserve is doubtful. And I think that you probably learned a lot from Satoshi's presentation about the possibility of that final scenario being present in the babies that we're speaking about. Really, for all the stuff that I'm going to talk about, though, other indications, respiratory ones and whatnot, they are not approved. They are approved for use in children without age restrictions relating to asthma and wheezing and sort of the allergy atopy type scenario. But I think that doesn't really align with how we think about extubation readiness or BPD. So I'm going to give two rationales for why we might consider using corticosteroid therapy and specifically hydrocortisone. The first is I think we all think about is the role of inflammation, right? Preterm birth is a inflammation-heavy scenario in most cases, chorioamnionitis and other things that are going on before the child is born that are leading up to the cause of preterm birth or maybe predisposing that child to a pro-inflammatory state. And then after they're born, they're exposed to the outside world, and we administer oxygen and mechanical ventilation. They're at high risk for infection, intermittent hypoxemia and hyperoxemia, and so on and so forth, all of which can contribute to inflammation. Downstream from that, we believe that those exposures put these children at high risk for BPD and neurodevelopment, and if they don't overcome that inflammatory burden, then they may be the subset of infants who are unable to survive their time in the neonatal intensive care unit. The second rationale that we considered is essentially what everything that Satoshi has summarized so far for us. I will note that, these children are at high risk of having an inability to produce cortisol, sufficient cortisol levels, perhaps just at baseline, but certainly while they are experiencing stress and they need to mount an appropriate fight or flight response. And there's a reasonable amount of data, and it's growing as time goes on, that suggests that decreased cortisol levels or decreased response to stimulation testing is found in children who develop BPD, have cardiovascular insufficiency, critical illness, PDA, and others. And I just show you one example of a paper on the right-hand side showing significant blunting of the ACTH stim response at about a week of age in very low birth weight infants who went on to develop BPD compared to those who did not. The sort of last of my sort of intro slides is this quote that comes from a paper from Lex Doyle, which I think summarizes nicely sort of where we're at with steroids. And he said that with greater than 80 randomized control trials of corticosteroids to prevent or treat BPD enrolling over 9,000 infants, and that number has grown in the recent years, corticosteroids are one of the most investigated medications in newborn medicine, and indeed one of the most used medications. And after such intensive investigation, one might be forgiven for thinking that the answers about who and when to treat and with what medication might be clear-cut. But alas, that is not the case. And I mention this so that you know the next set of slides are not going to give you all the answers. They'll give you some evidence and some insights, but it's not going to tell you what to do, when to do it, and how to do it with definitive clarity. I know we're talking about hydrocortisone, but I do think it is helpful at times to compare and contrast our two most commonly used corticosteroids, dexamethasone and hydrocortisone. Hydrocortisone on the right-hand side is the synthetic analog of cortisol. It's the exact same chemical formula. It's short-acting, half-life around 8 to 12 hours. It has, crucially, both mineralocorticoid and glucocorticoid effects, and the balance of which is active really may depend on the baby's stress state. More glucocorticoid during high stress states, less glucocorticoid during low stress states. And when we give low doses for reasonably short periods of time, it does not appear to suppress cortisol stimulation, even in our highest risk babies. Dexamethasone, on the other hand, is a synthetic glucocorticoid analog. It has no mineralocorticoid activity. It has very strong, very potent anti-inflammatory properties with a very long half-life. And there's certainly evidence that suggests that it for prolonged periods, and it can create a critical chemical adrenalectomy. And that phenomenon, paired with some other chemical properties of how this medication works, might be why dexamethasone has been shown in some trials to be a bit riskier. This is one study now going back 20 years, showing in animal models that when we give a single injection of dexamethasone to rodents, that we can produce neuronal cell death, and that will advance with age. That's what's shown by the black bars that are sort of increasing in height and are statistically different when compared to the other shaded bars. However, when they use corticosteroid, which is sort of the animal equivalent of cortisol, it appears to have a protective effect if administered with dexamethasone. So no neuronal cell death when we give cortisol alone, and potentially a protective effect when we pair that with dexamethasone, suggesting that the sort of absence of a mineralocorticoid receptor binding phenomenon in these neurons may be what's driving the real deleterious effect of dexamethasone administration to these animals and potentially to our infants. All right, so moving on to sort of the trial data that are out there. I didn't realize this until I became interested in corticosteroids and started doing research, but really the first effort that was put forward in neonatology to investigate the benefits of a corticosteroid were a trial looking at hydrocortisone therapy. This is by Baden et al. In 1972, where they took 44 infants with RDS and randomized them to receive 15 milligrams per kilogram of hydrocortisone within the first 24 hours, really sort of analogous to the things that we're doing today. And in that trial, they looked at short-term outcomes and found no effect on physiologic parameters, need for ventilation, or survival. So then for the next 30 plus years or so, people said, all right, hydrocortisone is not all that great. And we really focused a lot of our efforts on dexamethasone. That's not entirely true, right? But the bulk of studies that were done for a long period of time were focused on that. But after we learned about some of the concerns related to dexamethasone, there was an uptick in studies looking at hydrocortisone. You can see that the vast majority of the years in the trials that are summarized here that are present in the Cochrane Review are from the early to mid 2000s, far beyond a lot of the studies from the 80s and 90s that were looking at dexamethasone. So as I said, these are all the trials that are present in the Cochrane Review, and I'm going to kind of break down them by some individual studies and then by the summary meta-analyses. The largest of these that has been done for prophylactic studies is the Premilock trial. It enrolled 521 infants with a goal target of 786, but it was stopped early for some logistical reasons. Importantly, it enrolled infants born with gestational ages of 24 to 27 weeks, so no children whatsoever with gestational ages of 22 and 23 weeks. The infants received 8.5 milligrams per kilogram total dose over the first 10 days of age compared to placebo, and their primary outcome was survival without BPD. When I show results from these trials and meta-analyses, I've tried to make it a little bit simpler, and the things that are sort of favorable effects are shown highlighted with green bars. The things that will be shown with deleterious or harmful effects will be shown in red. If you're red-green colorblind, I apologize. Those are all going to be in gray. And then I've highlighted the statistical findings at the far-hand side in red. So these investigators found in the Premilock trial that there was a benefit for survival without BPD. the odds ratio here is increased because it's a positive endpoint. No significant difference for the outcome of BPD itself. No significant difference, although they're close, for in-hospital death, but a potential benefit for PDA ligation. They also observed that after about a week of age, there was a significant increase in the proportion of infants who were extubated successfully in the hydrocortisone versus placebo arm. At about day 7, it's a 10-point difference or so, and then by day 10, it's about a 15 to 16-point difference. They did do a series of subgroup analyses looking at the gestational age strata. They randomized the randomization was stratified by GA at 24 to 25 versus 26 to 27 weeks. For the primary outcome of survival with BPD, there was no significant difference between the two groups, and the direction of effect is in the same direction for both. However, for death before discharge, it did appear potentially, at least for the more robust size of the signal, that the benefit was restricted to infants that were born at 26 to 27 weeks gestation. And potentially concerning was an increase that was statistically significant in the risk for late onset sepsis or pneumonia in patients that were born at 24 to 25 weeks, with about a 17-point difference in the observed rates. Now, one wonders whether or not that's a spurious finding or something due to illness, or whether it might be related to the drug therapy itself. These data aren't going to answer that question for us for sure, but what this is a Kaplan-Meier curve showing the incidence of sepsis based on the postnatal age of the child. And as you can see, the timing of when there's a pretty clear jump in the number of infants who develop sepsis or pneumonia in the hydrocortisone group as compared to the placebo group seems to align with right around the time that this medication was discontinued. So close to between 10 and 15 days of age postnatal days is when that sort of big jump began, and it really doesn't persist in terms of increasing further much after that age. Olivia Bowd and colleagues did a series of follow-up studies, the first beginning at 2 years of age, and they really didn't find any statistically significant differences. By and large, the direction of effect was in the side favoring hydrocortisone, but none of them reached statistical significance, and this was not an outcome or series of outcomes for which that they had power to evaluate. It wasn't their primary intention, and it's also a series of outcomes for which they had a modestly smaller number of infants, and then within that group, some of them underwent more robust follow-up testing that would be analogous to the Bailey exam in our country, and some of them only went sort of standardized neurologic examination and parental questionnaires. Importantly, they looked at all of their various 2-year outcomes and looked for subgroup effects. They didn't find any statistically significant ones based on interaction testing, and so they weren't reported. One does wonder in the JAMA paper whether or not they had them all included in there, and then the editors made them take it out because there's sort of one line that says that we tested for interactions and we didn't see anything and they weren't reported. But they do, in many of their other papers, have pretty robust reporting of these subgroups. So for whatever reason, they didn't show them in the paper. They're not there. And so we're not even able to look for really small differences that didn't reach significance but might be sort of hypothesis generating. All right, and then an even smaller number of infants were followed up to 5 years. Again, no subgroup analyses here, but they did suggest a possible benefit, at least within one study center, for having a full-scale IQ greater than 90, improvement in working memory, and a non-statistical difference, but about a 16-point range in this composite outcome of having a more robust IQ, absence of cerebral palsy, and absence of autism spectrum disorders. So in general, possible benefit, no clear evidence of harm, but no, robust evidence either that there's a significant advantage for neurodevelopment when it comes to prophylactic hydrocortisone, as was studied in the Premaloc trial. All right, so next we're going to expand out to a larger group of the trials. And among those that are included in the Cochrane, I've divided them based on those that are sort of more similar in characteristics. Those are the ones at the top. Those were RCTs looking at low dose, similar to the Premaloc trial, prophylactic hydrocortisone. And then there's a series of other ones that we'll add in all together at the end that really had alternative indications or combinations of interventions. The 4 that are highlighted here are ones that are included into a meta-analysis that was published a few years back. And I've highlighted 3 out of the 4 of them in sort of that orange color because each of those 3 trials was stopped early. The Watterberg trial from 2004 was stopped early owing to concern for an increased risk of intestinal perforation. The Bonsant trial published in 2007 stopped early because the Watterberg trial stopped early. And then the Bao trial, as I mentioned, stopped early because of some logistical reasons. Only the one and the smallest of them, or nearly the smallest of them, ran to fruition. You'll also take a look at the population column showing that for the vast majority of these, they're again targeting the slightly bigger kids for whom that we're speaking about here today, or at least hoping to speak about. All right, so the Schaefer meta-analysis includes those 4 trials that I mentioned, some clear evidence of some benefits, but also some potential worrisome outcomes as well. So an increase in survival without BPD, a reduction in BPD at 36 weeks PMA, a reduction in drug therapy for PDA, and a reduction in in-hospital mortality with, for death, about a 5-point difference and a statistically significant relative risk reduction. However, similar to the single Premaloc trial, there was an increase in risk of late onset sepsis, about a 6-point difference, as well as an increase, about a 4-point difference in intestinal perforation. Analogous to the look that the Premaloc folks did, these individuals also did a series of subgroup analyses. They first looked at late onset sepsis, identifying similarly an increased risk in that among the least mature babies enrolled into the trials. And then the intestinal perforation signal does appear to be very strongly driven by co-treatment or co-exposure with indomethacin for a PDA. The Premaloc trial, importantly, did not allow the use of indomethacin. It did allow the use of ibuprofen beginning 24 hours of treatment initiation, and it did allow for use of acetaminophen at any point during the trial, but the use of indomethacin was restricted or wasn't really present in the study population. All right, and so then in terms of the full Cochrane review that includes each one of these trials, some similarities, some differences. No clear benefit for BPD among survivors at 36 weeks, so certainly the relative risk is pointing in that direction. There was, however, benefit for death or BPD, about a 6-point reduction, PDA, about a 7-point reduction, and in-hospital death, about a 4-point reduction. In this meta-analysis, there was an increased risk in the concern for intestinal perforation, about a 4-point reduction, but no difference in infection, contrary to the other meta-analyses in single trial, and no difference for CP among survivors or major neurosensory impairment. Kristi Watterberg and I were invited to write a Neo review about this, and I've just sort of had fun making these cumulative meta-analyses. If you haven't seen one of these before, I imagine most of you have. They're similar to other meta-analyses, but instead of having the data from each individual trial listed, they begin with the oldest one, and then they sequentially just add the new information from each new trial. And what this one showed, granted, there's heterogeneity in how these studies were done, and some of them are more similar, some had sort of other co-interventions or reasons for giving early hydrocortisone. But dating all the way back to that Batten paper, which I showed at the beginning of the presentation, there was that potential signal for benefit when it comes to mortality. And then that seemed to wane, into the early 2000s. And then it began to sort of emerge back. And it really wasn't until the Premaloc trial, the biggest of all of these was done, did that signal finally reach statistical significance with a relative risk of about 0.8, but a confidence interval all the way up to 0.99 for reduction in mortality. So what have the experts said about the use of early hydrocortisone? Well, Olivier Baud and the Premaloc authors in their follow-up paper from 2017 indicated further randomized studies are needed. Lex Doyle in the 2021 Cochrane Review and their co-authors said that more trials are needed. We need to have better long-term survival information about neurodevelopment. Hydrocortisone in particular shows promise, but the data on those long-term outcomes are limited, and the use of this really should be curtailed until additional research has been performed. And it seems like what we saw from the survey data that Helen presented at the very beginning, that many folks are sort of heeding these recommendations. When we look at sort of more national recommendations or guidelines, the AAP statement from Jim Cummings says routine use of postnatal corticosteroids can't be recommended. And then finally, the Europeans, again, sort of hint at this promise with hydrocortisone prophylaxis, but that more work is needed. And in particular, as this group, I think, would agree, we particularly need more information about the babies born below 26 weeks gestation. All right, so we talked about early, right, the first week. Now we're going to talk about interventions or hydrocortisone administered after the first week. There's 2 big trials that have come out in the past decade or so. The first is the STOP BPD trial, predominantly a Dutch trial, but some enrollment elsewhere. This study enrolled 372 infants with gestational ages less than 30 weeks or birth weights less than 1,250 grams. The mean gestational age in this was about 25 and a half weeks with an interquartile range, or I should say the median, then the interquartile range was about 1.5 to 2. So, getting down to that 24-week mark, maybe a few 23-weekers, but certainly not the bulk of the patients who were enrolled. The babies that were participants had to be intubated at 7 to 14 days of age and had to have a mean airway pressure multiplied by their administered FiO2 greater than 3.5 to be eligible. They received 72.5 milligrams per kilogram total dose of the medication over a 22-day gradual weaning period were compared to placebo, and death or BPD at 36 weeks was the primary outcome of this trial. So for these data, no difference for death or BPD. They did provide some subgroup analyses, and for those born less than 27 weeks, also no difference, almost identical observed rates in that subgroup as compared to the hydrocortisone group. They did show a benefit for extubation. Here they call it failure to extubate. So, the failure to extubate was lower, meaning more children were extubated in the hydrocortisone group. And this was true at every point that they look. I show you the one at day 7, but day 3, 7, 14, 21, I think out to 28 days or something like that. After receiving the drug, did they have significant reductions in extubation failure in the hydrocortisone treated group? There was benefit for death by 36 weeks post-menstrual age that sort of narrowly made it to statistical significance. It's always one of those things where you see the confidence interval has like 6 or 7 digits to it. Here, not quite that bad, 0.995 for the upper confidence round. But a potential benefit, and anything that we can get for mortality is always something that we're very keen to identify. And in this subgroup, contrary to what we showed from the Premaloc trial, it did seem like the babies in the smaller gestational age versus the large gestational age group might have been the ones who had those gains. And then oddly enough, or maybe not oddly, but one of the things here is that even though there was this significant difference, these are pointing in opposite directions. The sample size is small, 32 babies in the hydrocortisone group, 31 babies in the placebo group that are bigger than 27 weeks, but with a relative risk or hazard ratio that's in the 2.5 range or so, suggesting potential harm, but again, with small sample sizes. And then finally, hyperglycemia, treatment of hyperglycemia with insulin was increased in the hydrocortisone treated babies. All right, next, 2022, Kristi Watterberg and colleagues from the Neonatal Research Network published the largest trial of corticosteroids to be done in neonatal medicine. It's always interesting to present somebody else's work in front of them, but we'll do my best and she'll correct me when we're done. The investigators enrolled 800 infants, gestational age is less than 30 weeks, a mean gestational age here just under 25 weeks with a standard deviation of about a week and a half. So again, maybe getting down into those 23 weekers, but most likely not the dominant population. Eligible infants were intubated for greater than 7 days, and they had to be enrolled at 14 to 28 days of age. They began with 4 milligrams per kilogram per day initial dose, and it was tapered over 10 days. I think the total dose ended up being just over about 1 milligram per kilogram in dexamethasone equivalents. So pretty similar to the DART regimen, which is about 0.9 milligrams per kilogram. They compared it to placebo, and they had 2 primary outcomes. One was an efficacy outcome, survival without moderate to severe BPD at 36 weeks post-menstrual age. And one of them was a safety outcome, survival without moderate to severe disability at 2 years of age, meaning they were evaluating whether hydrocortisone would improve survival without BPD without a co-occurring harm with a detriment for moderate to severe disability. All right, what did they find? Analogous to the STOP BPD trial, they showed improvements for successful extubation, relative risk of about 1.5 and a little over a 10% difference between the hydrocortisone and placebo group. But for the primary outcome, survival without BPD, and the safety outcome of survival without moderate to severe NDI, no statistical differences between the treatment arms. In this trial, they did observe an increase in risk for treatment with antihypertensive medications, with about a 3-point absolute difference between the two groups. Importantly, the need for this treatment resolved after therapy was taken away, and there weren't any long-term observed consequences in the sort of cardiovascular realm. So just sort of one chance to compare against dexamethasone. How, when we think about extubation success, because that's really some of the consistent themes between these later hydrocortisone trials. How does the use of hydrocortisone compare to the use of dexamethasone? So these data are comparing the results from the Cochrane review on the dexamethasone side to the Watterberg trial on the right-hand side. Similar benefits for extubation at about 7 to 14 days. The sample sizes are clearly different, but a relative risk of about 0.6 or so on the dex side and about 0.8 on the hydrocortisone side. So this is not definitive. These are not head-to-head trials by any means, but it does make one wonder whether or not dexamethasone, particularly since we know that it's a much more potent anti-inflammatory drug, whether that might be a little bit stronger when it comes to extubation success and sort of temporary improvements in pulmonary mechanics. But we remain concerned about some of the side effects related to dexamethasone and certainly all corticosteroids in general. So there is a Cochrane review that was published in 2021 by Lex Doyle and folks, but you'll recall that the Watterberg and the NRN trial came a little bit after that. And so Kristi and I, in our Neo Reviews paper, sort of recreated the systematic review, but added in the NRN trial. It shows here the outcomes for death or BPD, BPD at 36 weeks, death at the last stage, cerebral palsy, and death of cerebral palsy. We looked at both DEX and hydrocortisone and compared them. Again, green are the favorable findings, red are the unfavorable ones, and the non-shaded ones are the null findings. And if you draw your attention to hydrocortisone, we've stratified it by timing, again, early versus late. For hydrocortisone, there was benefit in the full Cochrane plus the Watterberg trial for the composite outcome of death or BPD with a relative risk of about 0.9. So small treatment effect, but nonetheless benefit, as well as a modestly more robust observed benefit for death at the last reported age. No difference for BPD itself and no difference for long-term neurodevelopmental outcomes. Contrast that to the later use, greater than 7 days at the time of initiation, and no benefits or harms whatsoever for these evaluated 5 outcomes with the use of late hydrocortisone. And so finally, I'm going to wrap up with this notion around the sort of which babies should be treated with these medications as it relates to sort of preventing BPD or longer term outcomes. And this is an updated meta-regression that was done by Lex Doyle and colleagues. I'm sure many of you, if not all of you, have sort of seen an analogous slide by this. Lex Doyle and his group were really the ones who put on the map the idea that we might want to be more focused on treating the highest risk infants and avoid treating the lower risk babies because of this trade-off between the beneficial versus harmful effects of steroids on neurodevelopment. And so this is the newer update from that. The previous ones have the slope going in the opposite direction because they're looking at death or CP as the composite outcome. Here, they're looking at the survival free of CP, so a beneficial effect. The bottom left-hand side of the curve shows that we're favoring the control group, meaning if the BPD rate in the control group or if the underlying risk of BPD in the infant is on the low-hand side, it probably doesn't behoove us to treat those children. But if the baseline risk of developing BPD is on the higher side, generally that cut point being around 50%, with the confidence interval closer up to around 60% or so, then there may be an overall balance favoring the use of steroids, both for BPD prevention possibly, but for reduction in the risk of cerebral palsy. I went through all of that because this was the first time that they felt that they had a sufficient number of trials to divide the two sets of studies based on whether dexamethasone was the drug of interest or whether hydrocortisone was the drug of interest. And what you see on the left-hand side is a curve that looks very similar to the one that I showed you before. Don't treat the healthier babies, probably do treat the sicker babies, with an even more robust sort of slope to the curve, suggesting that that we may be really getting a big bang for our buck in the highest risk children. On the opposite hand, though, is the hydrocortisone data, which is pointing in the opposite way. It's important to note that the slope of this line is not statistically significant. So it doesn't mean that there's an observed treatment advantage in the lower risk group and a treatment harm in the higher risk group. But it does make us wonder whether or not this is really just sort of an across-the-board effect. We haven't seen any differences in the longer-term outcomes in all the trial data that I've shown you, even though the Premaloc trial sort of raised the question of maybe there might be some benefit. but there isn't any clear evidence that we should have this sort of calculate the baby's risk and consider whether or not we should give it if we're thinking about hydrocortisone. But if we get more data out there, one wonders whether or not this trend might be maintained, and if we would sort of flip the balance on its head compared to what we do use for dexamethasone. I'll caution all of that, however, that we a few years ago put out an observational study looking at children who were treated with either dexamethasone or hydrocortisone, comparing them to propensity score match controls. So these are observational data, not trial data. All babies born less than 27 weeks gestation, all treated after the first week of age, sort of analogous to what I think the AAP recommendations are, that we shouldn't be using these drugs early. And we found a very similar trend for both corticosteroids. So we didn't see that it was only dexamethasone. That was the one that favored use in the high-risk babies. It did look, at least in our data, that the direction of benefit was consistent between the two medications. All right, so wrapping that up, there are no robust data to inform the use of hydrocortisone for respiratory or neurodevelopmental indications in infants born less than 23 weeks. I probably could have led with that and then given you back 20 minutes of your day, but we'll get a chance to review those other data. Early hydrocortisone initiated in the first week may reduce mortality, but the subgroup data, at least from the Premolog trial, suggests that benefit might be restricted to the babies born larger than 25 weeks. Might also reduce the risk of BPD. Doesn't appear to be any subgroup difference there. It may increase the risk of sepsis in the infants born less than 26 weeks. Unclear about the tiniest babies, of course. And the effect on longer-term neurodevelopment is uncertain. Maybe some benefit in Premolog, but when we aggregate all the data, it doesn't appear that that's the case. Switching to later hydrocortisone, initiated after the first week, this clearly promotes extubation success. This has been observed across studies, and it does appear to generally be similar in efficacy to dexamethasone, but maybe slightly weaker, although again, those are not head-to-head comparisons. Possible adverse effects include hyperglycemia and hypertension, and there again doesn't appear to be any apparent either good or bad effect on neurodevelopment. And this is really the one circumstance where we're at or near to having the kind of power that we want to evaluate those longer-term outcomes. And with that, I will conclude.
Great, thank you so much. We'll get started with discussion as we do. There were several comments, questions that were put into the chat. Just please note we're not able to type in a response or others to see those. If you are able to move this into the Q&A, we can potentially answer more of those.
I want to thank both of the speakers for really illuminating talks on this area that we know nothing about. So to move on, a lot of the questions that were submitted ahead of time and a couple in the chat had to do with dosing and weaning and what to do when hypotension recurs when you're weaning. And I've dealt with this for many, many years. And I even see that in terms of the dosing that people are giving, they're still giving dosing like 1 milligram Q6, 1 Q8, 1 Q12. But when I looked at the pharmacokinetics of it in a very tiny pilot study, it was clear that those kinds of doses produce very high levels. And so when we did the randomized trial, we used 0.5 per kilo Q12, which did increase the average cortisol level by about 5 micrograms per deciliter. So I think that first of all, I think that we tend to overdose the kids, and we need to realize that the half-life for babies who are this immature is very, very long, 8 to 12 hours perhaps. We have very little data. And that when you give them a higher dose, what's happening is you are suppressing their own adrenal axis, and therefore people are having trouble and asking questions about when you are weaning, then what do you do when you get a recurrence of hypotension? So I would suggest that you start with a lower dose. This is only in the first week or a little bit after, and just leave it at that unless you need to increase it for additional hypotension. So that was one area. And then, there's a question that says, shouldn't we be dosing based on body surface area? This is true, but when you look at clinicians and how they operate, they are used to using milligrams per kilo. So I simply translated the dosing of per meter squared body surface area into a milligrams per kilo dose for these tiny babies. And that's where I came up with the dosing. The other question is whether you should get the questions that seem to be prominent. Should you test a cortisol level before you give the hydrocortisone? And should you do an ACTH challenge ahead of time? So my answer is no and no. And I think that Dr. Kusuda showed pretty well that the cortisol levels can be normal or high or low, and you don't really know what to do with it. And in my mind, at least, it doesn't matter what their ACTH response is, because what matters is their response to the critical illness that they are currently undergoing. And so even in the adults, as of a few years ago, who used to say do ACTH challenge, are now saying if you get the hypotension, inotropic, unresponsive, just go ahead and treat with hydrocortisone. Don't worry about the ACTH challenge test because it doesn't really help you very much. So those are to start off. And then
Kristi, I can jump in with some of the questions from the Q&A.
Yeah, please.
There's a question from Annie Janvier for the panel. What are your thoughts about hydrocortisone as the first line of intervention for babies less than 25 weeks when they have clinically significant hypotension? I'll let Satoshi or Erik or anyone chime in.
Okay, so in my talk, I suggested step-by-step approach because, of course, hydrocortisone may be effective, but before that, hydrocortisone has, of course, always side effect. So if possible, we should avoid the use of hydrocortisone. So if baby has hypovolemia, if baby has another reason, maybe we should treat that situation first. So I personally don't think first-line use is not feasible if for baby, very tiny preterm infant.
Thanks, Satoshi. There's a question from Bet Manley from Australia. If you were to do a new trial of prophylactic hydrocortisone, if you could compare the Premilock course and another different course, either lower, higher, shorter, longer doses to placebo, what would you choose?
Erik, that must be for you.
I would choose the exact same one. The trials that Schaefer and Kristi put together in their meta-analysis are pretty similar in terms of cumulative doses and duration. There's some subtle differences, a couple of days, maybe a milligram or two here, maybe a slight difference in the starting dose. But I think what the real benefit in my mind of the Premilock trial when it comes to preparing for or designing a future study is that we have, for the first time, I think, robust, good sort of phase 2B to phase 3 trial data here for longer term neurodevelopment that would support an indication. So a group of infants, it would support a dose and a duration and would demonstrate the potential benefit for longer term neurologic outcomes and certainly the accumulating evidence promoting possible benefit. So combining that with the sort of recommendations from the Europeans and the American group and like Stoyle and the Cochrane that really point to the fact that we need to address the use of this in tinier babies, one thing, and we need to have more robust longer-term follow-up as the second thing. I would lean on the Premilock design quite heavily, increase the gestational age or decrease the gestational age down to the type of kids that are interested in this lecture group here, and be powered to look for longer term outcomes. I don't see any compelling evidence that we need to sort of go up on the dose, and going down on the dose maybe, but then you're working blind again. So I think that they've got a great precedent for us to work off of, and that's what I'd suggest to start with.
In my study that did get stopped early because of the indomethacin effect on spontaneous perforation, we did see that dose increased blood pressure significantly in the kids that got that versus placebo. So it was effective for increasing blood pressure. And we also did tend to see a positive effect at 2 years in fewer of them had a Bayley mental developmental index of less than 70. So they also had an increase in object permanence measures at that time. So I think I agree with you. There is enough evidence, soft evidence, but I think to suggest that that's an appropriate dose.
I could also point and address the question about if it's a good idea to check for cortisol levels, serum cortisol, before starting off with hydrocortisone or not. There were some questions about that.
So again, first of all, it's very difficult to measure the cortisol level in preterm infant because there are many other metabolites cross-reactive with antibody. So if we use immunoassay, it doesn't mean true concentration of cortisol. And also, Kristi already mentioned, there are two types of adrenaline insufficiency with decreased cortisol level and also normal or higher cortisol level. So in clinical point, it doesn't matter. So I do not recommend to measure the cortisol level before using hydrocortisone.
Right, nor do I. Annie Janvier has addressed a question directly to me, so I figure I should answer it. I agree with you, Annie, or I think I agree with you if you're agreeing with me, that if the indication is inadequate adrenal function, the appropriate first dose in the absence of hypovolemia would be hydrocortisone replacement rather than an inotrope, which should not be what they're missing.
One of the other things in the text here was relating to a secondary analysis from the Premilock trial that raised concern that in the children who had higher baseline cortisol levels typically from the umbilical cord, that it might be harmful in those children to receive hydrocortisone with an increased risk in IVH. And I think, Kristi, in some of your work, you saw also some concerns that suggested that in the maybe adequate cortisol kids, maybe there's a difference in treatment effect for one of those outcomes. I think that's of interest. I think as we get into slicing and dicing the trial populations into smaller groups, we need to be cautious about whether those findings are robust or whether they're potentially due to chance. The Premilock work is very interesting and hypothesis generating. The normative ranges in that trial were derived de novo in the population and not based on sort of existing normative values in larger groups. And they also come from the cord blood predominantly, which may not be the best marker of the baby's sort of baseline state or stress state in the first 8 to 12 to 24 hours after birth. And so I think those are things that we should be looking into, but I'm not yet certain that they provide convincing evidence that a pre-cortisol level should sort of lead down the path of who should get it. And certainly in my mind should not lead down to the path of which child should versus shouldn't be enrolled in a future prospective trial.
Right. And before we were ever giving hydrocortisone in trials or otherwise, it was shown that a high cortisol concentration was associated with an adverse effect of IVH. But in the trial, when you give hydrocortisone, it did not affect the incidence of IVH, even in the ones who had higher cortisol concentrations.
Sort of related to that, Kristi, there's a lot of questions we're not going to be able to get to. Many are surrounding dosing. But one of the questions I think is interesting is about extrapolating the Premilock trial to babies who were not included, including those at 22 and 23 weeks, which of course is the focus of the TBC, as well as babies with IUGR. So I guess for the group, how do you extrapolate these findings to those babies who we know are quite different?
So in the work that we've done previously, granted very few 23 and no 22 weekers, as you get down in gestation, the incidence of adrenal insufficiency gets higher. And so I would physiologically, fetal-wise, everything else-wise, I would infer that the babies who are 21, 22, 23 weeks will have an increased incidence of adrenal insufficiency rather than anything startlingly different.
And one of the comments was specific about IUGR and the risk of intestinal perforation in that group.
So they do have an increased risk for IUGR babies in many people looking at them. The thing is that the IUGR babies have an increased incidence of adrenal suppression because they have a smaller placenta. They're seeing more maternal cortisol for a longer period of time. And so they are at an increased risk actually for adrenal insufficiency. In the absence of indomethacin, randomized trials have not shown any increase that I'm aware of in intestinal perforation. However, you will always hear anecdotal evidence because what is there, a 5% incidence in this population of a spontaneous perforation? So you're going to see it. And the question is it related or not?
Thank you so much to our moderators and speakers. As usual, we could continue the conversation for some time, and we probably will, but thank you all so much. Thanks to our participants. And this will be posted to the website in some short time. Thank you all.